Okay, friends, now we are going to start the third, almost the last technical session, which talks about the participation of PwD in disaster risk reduction process. We have been discussing this since morning, that how that inclusive arrangement have to be made in terms of that bringing all at one platform and going from here for the risk reduction. And for that, process is very important, and the need-based was highlighted. So the main highlights were the need-based. So need to know from various disabilities, whether disabilities leading to abilities or abilities we are considering our perception is to disability. That we need to understand, and the focuses which have come from the states, that how they are going ahead with that in terms of execution, ministries and the department. In fact, the disaster risk reduction itself is a kind of a combination of uncertainties and the response. So when we talk about uncertainties, we never know that when disaster would strike. For some disaster, yes, it is known, but some disaster, it is unknown. So one size fit to all will not work. Maybe the processes have to be defined for earthquake differently, and the cyclone and flood require different treatment. So in this connection, when we talk about people at disability and the number given by the Executive Director NIDM in the morning session, that the number of deaths is 3 times more than the normal person who is dying in the disaster. So this is very, very clear indication that exposure of risk of people at disabilities are very, very high. So almost we can take as a 100% probability. So if we take this as a 100% probability, what kind of a processes which we need to look at? And that is this major challenge. We have to address this issue. Pradip Nayak from Orissa State Disaster Management Authority. We have Dr. Jayakumar from National Institute of Mental Health, NIMHANS. Then we have Dr. P.T. Baburaj from Kerala and Dr. M.C. Anila from Kerala. And this process, I would also highlight that men with disability and women with disability, this will also have a differential vulnerabilities. So that processes should not be taken as a kind of a one size fit to all again. So that differential vulnerabilities are to be addressed differently. So let us see that how our people, they have to say in terms of the panelists approaching this problem, differential vulnerability and the processes designed for it. So this is the National Institute. So I would request first to Dr. Jayakumar to speak on the subject. Dr. Jayakumar, and then we will request co-chair to comment upon at the end. Huh? Thank you, Chair.
Thank you, respected chairpersons, dignitaries on the dais, off the dais. My special thanks to the Executive Director of NIDM for organizing this important consultative meeting. In fact, this is the second one. They've already taken the step which was most neglected for most of the time in any disasters. So we all know actually that India is a theater of disasters. We have everything hands full, and it has been actually going on for years and years. We have so much of diversity. Fortunately or unfortunately, we have so much of the other side of the things also happens, negative side. So yet we are all one proud Indian. And I'm not going into the disaster profile of India. We all know that. NIMHANS, National Institute for Mental Health and Neurosciences, which is an institute of national importance by an act of parliament. And we have been working in disasters, specifically to the disaster mental health and psychosocial care for last 3.5 decades. So we work in every phases of disaster with every population. And what is that actually we have to offer here in terms of empowering this population, this universe? So usually the core issues which we come across among the disabilities, the barriers, number of things which we all aware of it. In terms of barriers, in terms of inadequacies, in terms of accessibility, in terms of attitude and perceptional differences among the various stakeholders, and inadequate information and communication, and added to that the infrastructure, the political will, and added to that the collective community's participation. So I would like to take you across what is that actually that the science offers when they were classifying the people with the disabilities. So it started in 1980. So this is what actually that it all started with a disease, then or a disorder, impairment, disability, and we gave them a name called handicap. This was in 80s. So what is that actually the approach which used to be there and which has to be followed and which we are following it? The problems. Earlier, it used to be a personal problem, but it's not a personal problem, it is a social problem. It is no more the medical issue, it is a social integration aspect is need to be taken care. It is not that individual intervention, action, it is a social action is needed. And it is not just a professional help, it is an individual and collective responsibility. And it is just not about the personal, it is actually also an environmental manipulation. When we come here, is there anything which is easy for a person with this population? And the behavior, it used to be about the behavior of the person with that difficulty. And today, it has to be an attitude, a collective attitude from everyone. And the care, it is no more the care of the person, it is also the rights of the person. And the healthcare policy, it used to be, but today there needs to be a political also actually need to be involved. And individual adaptation was emphasized previously, and now we need to look for a social change of this population. And the theoretical framework, again, it says that it was mostly of a medical model before, and we need to actually graduate into a social model. So it used to look at the human functioning. It needs to look at the human functioning, not merely the disability of the person. It need not be the minority, no more actually the minority. It needs to be the universal model actually. And it requires integrative sort of a support. It cannot be actually merely a medical or a unilateral sort of a support. It needs to be a multidimensional sort of a support. And it needs to be an interactive model and not a linear progression. And the parity, we cannot actually keep on going with the etiological aspects of disability, rather than we need to actually bring in the parity between the population. And the context, that needs to be inclusive, and which is very much missing in the disaster management and disaster risk reduction. It is as per se completely missing. If you look at actually the MDG goals, we are talking about actually empowering billions of population, but glaringly, this aspect was missing in MDG goals. And the same thing actually, you look at actually the Sendai framework. And my own specialization area, the psychosocial care and mental health, this is also missing in the DRR Sendai framework and MDG goals. So, the cultural applicability, somebody was talking about the cultural applicability. We are very good in actually taking it, but we also need to give in something actually which is very much our own actually aspects from our own culture. And the operational, any intervention actually in disaster risk reduction or a disaster management, it need not be a theory driven, it should be an operational, applicability driven sort of a approach. Then only we can actually empower people with these people. And it need not be only the adult driven. If anything actually in the area of disability, it is only about the adult, only about that point of a time. It should be actually taken on a lifespan. What is that happening? For example, when I was working in Car Nicobar Islands, post-tsunami, There were a number of disabled were there. Registered disabled were around 600. What happened to them after 10 years? Have we have a data? Have we have a study? Have we have a follow-up? People say that actually it was a normal mortality. You won't find actually around 30 or 40% of the people after 5 to 10 years. But it is not so. The lifestyle struggles which comes after a disaster, the struggle for the life, the lifestyle changes, this may actually reduce the your life expectancy. So that is what actually that we need to have a lifespan coverage. So we don't look at actually that disease and that angle. We more actually look into the environmental factors, personal factors, and activity limitations. And holistically, actually, we need to actually look at while doing actually any sort of DRR problems. So it is actually just not an impairment. It's about all those aspects which was mentioned in the left side. So the approach which we follow is actually the universal model, not the minority model. So it is multidimensional continuum sort of a support we need to provide to the disabled. I'm just skipping some of the things, which is actually I have already mentioned it. I think I can take some questions because it's only 15 minutes time.
Okay.
So some of the aspects actually, personal and environmental aspect actually needs to be included, and the cultural applicability is actually very much is should be in sync. And what is that actually we need to look into the DRR? The patient or the person? No more the patient, it needs to be the person. And what is that actually we need to look into the DRR? It is the ability, the strength of the person, not the disability of the person. And the functioning, the functionality. It says that the mental health says that, any distress leads to dysfunction. So what is that functionality aspect of these people in a normal sort of a time, non-disaster time? And the activities, not the disability, and the participation. So we need to actually include, are we including these aspects into the DRR aspect? And that is our question, which actually we even ourselves struggled to answer when we started working on the disaster preparedness and risk reduction. So what are the tenets actually that? The higher the distress, the higher the disability, lower the coping, lower the resilience. So that is where actually that we need to work on a psychosocial front when we are working it, because psychosocial care is a cross-cutting area which cuts across every population, whoever actually in the community or some, society which actually are affected by the disasters. These are all some of the long-term and short-term issues which we usually see in the disasters, and which amplifies for this disabled people in a post-disaster scenario. So this is actually one of our experience back in India in natural disasters and a man-made disaster. So the distribution of distress among the survivors is actually that human-made disasters are much, much higher than the natural disasters. So survivors at risk, we are talking about survivors at most of the risk, and this is some of the things actually, studies which we have conducted across the country, where this is actually the health-seeking pattern of people in the community are there. In this, I would say that people with disabilities are actually not even minuscule actually that. So rebuilding of structure is possible post-disaster. Is it possible for the healing of mind? So what is that we need to do in a disaster, post-disaster? Preparedness, risk reduction, mitigate the effect of trauma, alleviate psychological distress, and strengthen the resiliency, and re-establish normalcy of the persons and normal development process for the children. So activities, actually, these are all some of the activities which actually psychosocial care services try to address, promote psychological and social well-being, building up their resilience to help them to overcome the trauma and distress, develop trust in others. Somebody was talking actually that the lack of trust, how to trust actually that's what happens, develop hope in the future. So this is actually some of the difference between the disaster mental health that actually takes care of the long-term needs mental health needs, that is actually, we call it as a disaster mental health. And psychosocial care actually promotes independence and dignity of the individual. So that is where actually, along with actually reducing of the distress and preventing the person moving into a pathological domain. So the aspect is actually in DRR or in the mitigation or a preparedness, it always used to be actually the integrated sort of a support, which needs to be a multidimensional and cross-cutting. So the challenge here is that, yes, we are talking about all those things, psychological support, psychosocial care for all this population. Are we in a position to provide? No, absolutely not, because India, for a 1.25 billion population, we have hardly 10,000 mental health professionals for a normal sort of a community. So in disasters, as I said, actually, that mental health issues amplifies, and this is actually a very crucial special population, and we don't have professionals actually to handle it. So the community participation is crucial here. So some of the things actually we were working with the communities, and I think some of the organizations are here. Two I can mention, SAMA is one, and CBM. We have we've been working with them for a longer period of time, and Handicap International also. And we have developed a number of modules and capacity building trainings for these organizations for the community-based care. So we work with every people who are available, who are ready to provide support. Yes, sir. So these are all some of the things which we developed for entire that 14 category of people mentioned in the Act. So this is actually some of the things. And what is that presently we are doing? We are actually taking up a DRR in 6 cities, integrating psychosocial care as a pilot along with the MHA and USAID and UNDP, and WHO is also partnering us. And in this, we are actually also focusing on the preparedness for the disabled and DRR on psychosocial care aspect, which is currently in 6 cities, which will be taken up to next 60 cities in the country. So the thing is that here, deprofessionalization. We have certain capacities, we have certain knowledge, and we have certain skills. We will be happy to actually share all those things and to work with each one of you in the coming days. So the thing is that the shift is not the one, it is the universal. So presently we have one of its kind of a center running in NIMHANS. This is Center for Psychosocial Care Support for Ministry of Health. This is nowhere else in actually Asia. Actually, this is the only thing which is entirely looking at the psychosocial care component. So with this, I end my short presentation. I congratulate and compliment NIDM for taking up this. Thank you, Chase, and
thank you very much, Dr. Kumar. Been able to highlight that how NIMHANS is taking up this issue at different front, different level, especially when it comes to the psychosocial care, which is one of the most important category when we talk about the process. And that process is leading to empowerment. And empowerment itself is a political process and a lot of things to be done. So the one point of intervention you mentioned about that could be in a more institutionalized manner if we take up the psychosocial care for the affected people, and going into preparedness would do will give better result. In fact, disaster risk management has a complete cycle, and that cycle is not just confined to the post-disaster trauma or post-disaster impact. One aspect is the disaster response, another aspect is the relief and recovery, another is the relief and rehabilitation, long-term recovery, then it comes to the preparedness and also comes to the risk reduction, that is mitigation. So when we are talking about this empowerment process, that how we should be dealing holistically, so that the comfort should come up, like that even if we are taking this forward, we have that all the strategies at one table, so wonderfully classified by him that how post-disaster trauma would be taken up. So we will also listen to the person who have been into the process for long. So I will invite Dr. P.T. Baburaj, and from Kerala. We have listened the story of the government from the Kerala. So we are now listening the story of the other side, so how they are going to present this as an issue. If you suggest some risk mitigation strategy also, or either you can focus also that.
Respected dignitaries on the dais and off the dais. Myself, Baburaj. I'm a differently abled person, and I'm working as an associate professor and honorary director of one Inter-University Center for Disability Studies in Kerala. And we got an opportunity to conduct, interact with my people, especially Kerala. Right now, more than 12 lakh people being as a differently abled. During when I'm talking about my basic information, I'm a associate professor in School of Behavioral Sciences, the only university in providing special education in MPhil and PhD, I think so, and in medical for medical science. Those who are completed MD or MS or any other PG course in medicine, they are also pursuing MPhil and PhD in our department, and also MSc Psychology and MPhil Rehabilitation Psychology and PhD Rehabilitation Psychology, and also MPhil in Rehabilitation Nursing and PhD in Rehabilitation Nursing, and MG University Kerala, I think so. And myself is associate with the honorary director of Inter-University Center for Disabilities. It's a center established by Government of Kerala under MG University for looking after and conducting research or any academic activities for the differently abled. During that time, I happened to attend a training program at Trivandrum conducted by KSDMA. And I joined a 3 days training program, TOT program, and I submitted a proposal for conducting a research proposal mentioned strengthening emergency response capabilities of the differently abled in Kerala. That is the title given, and they have approved the title. And this disaster risk reduction is the systematic development and application of policies, strategies, and practices to minimize vulnerabilities and disaster risk throughout the society to avoid or to limit adverse impact of hazards within the broader context of sustainable development. That was my area. This is my department, vision and mission, just skipping IUCDS, as I told you. This is the best memorable days in my life and my pupils from Kerala. And when this report is being submitted in UN, then Kerala State Disaster Management Authority representing the program, and our Honorable Chief Minister also joined, and they sent a letter. The KSDMA Member Secretary, Dr. Kuriakos, sent a letter from UN. We are happy to inform you that Dr. Eddie Nutpo, UN Secretary General's HEG advocate, visited Kerala Pavilion. He was overwhelmed to seeing the Disability Inclusive DRR program of Kerala. He took the handbook in Braille with him and expressed his desire to visit Kerala and learn from our experiences. He said that he is moved and touched deeply to see this model initiative of Kerala for considering differently abled right from the preparedness stage. KSDMA hopes to host Dr. Eddie this year. KSDMA is humbled by the recognition of this initiative by Dr. Eddie. Not that. The World Reconstruction Conference this year is focusing on inclusion. Kerala laid the foundations of this in 2015 and launched it in 2016. This is the project which I started. The heroes of the project are Mr. George Lewis, just presented his paper, SDMA, Dr. Baburaj, IUCDS, and Dr. Hena was a coordinator, state coordinator, including Dr. Anila Kumar is sitting in the dais, and Mr. Sabitumar of a tunnel. So this is a person, great person, sitting along in the wheelchair, along with the Member Secretary of Kerala SDMA. So this is a brief note from the great office UN we got. So we were very happy because this humble effort made for the humble people in Kerala, so that can create a worldwide eye-opening scenario. So this is the projects and these reports reported in Malayalam news dailies. And skipping some areas. And the main objectives of the empanel a cadre of experts as resource persons in the field of disability inclusive disaster risk management, and create awareness among the teachers, parents, caregivers about disability inclusive disaster risk management across the state, empower the persons with disabilities to prepare for disasters, emergencies, strengthen the emergency response capabilities of persons with disabilities across the state, to develop sustainable plans to strengthen the capacities of the differently abled in DRR. And we are conducting TOT programs among basics on disaster management and disaster risk reduction, understanding disability vulnerabilities of persons with disabilities in pre, during, and post-disaster periods, measures to reduce risks of persons with disabilities, basic first aid and survival skills, etc. And brainstorming sessions, lecture, participatory discussion, experience sharing, feedback, simulation games, self-analysis, case studies, etc. were conducted. And training is also done. And finally, the method of implementation, students with a visually impairment. We conducted this program for 4 days. First day, students with a visually impairment, minimum intake 40, but in many districts, in Kerala, almost 14 districts are there, but in Malappuram district, where we permitted 40 participants, but more than 120 people joined this program. And the second day also, we conducted as for the speech and hearing impaired people. And the third day, locomotor disabled. And fourth day, persons with intellectual disabilities, especially students or the caregivers. And key learning activities and outcome. Then the participants is a response. See, this is from my experience. Myself, a physical disablement, and I take the initiative. And we trained more than 110 trainees. Among 5 committed fellows joined with my program, and we started the program at PwDs district, Kerala first, the most vulnerable district in Kerala. Dams and landslide and floods is always troubled in this district. If I started first, and from the next, immediately after the great floods came in Kerala on 2018, 14, 15, and 16th of August. And which adversely affected the program. And after 1 month, we started again other districts. This scenario is that people are very eagerly waiting this program, and they are opined that never they have been such experiences. This is the first time differently able people is being considered and giving this kind of program, especially empowering their capabilities, identifying them. They need a special care and support. At least sometimes normal people cannot be supported sometimes, but these people can. Yes, this course will, this training, this short-term training may help us to empower our mental abilities and capabilities. So they opined, and again, their final opinion is that, no, this is a simple a group of 40 or 50 or sometimes 100. Intake is 40, but I determined to take those people who are coming eagerly for attending the course. I take the responsibility and give whatever may be the number. No, I cannot consider, and give maximum personnel opportunities about attending. I always, usually in Kerala, this kind of program we're conducting, they are getting some TIDA, that means on 100 rupees or 120 or 150 maximum. But these people are asking, no, we don't want any money, any support, any other resources, but we need certain this kind of training again. So recently when I joined one group yesterday, there was a program conducted by Univeristy, 5 days research methodology courses, where I take one class on the last day, and I presented this topic differently, disability and DRR and other social attitude. And the 150 people from colleges and universities, they are take it a serious matter, and they are seeking appointments from, especially now 18 colleges have given their consent to conduct this kind of program, should be conducted in colleges, especially among students in colleges. So from my opinion, yes, still we have to go to move to higher education level and school education level, grassroots level. So this is these 14 districts experience has been a great opportunity to me to understand the differently able people in Kerala. Especially I am a member in the State Advisory Board on Disability. An expert member is being appointed. So I have a right to call any government office directly. Persons who are calling me, telephone me, please sir, I'm having this problem. My family problem is there. I am not getting pension. I'm not getting proper housing facilities. And a lot of problems. The grassroots people need basic requirements. Immediately I contact the concerned authorities, whether it is a district collector or district authorities or a social legal department. Immediately they will respond, sir, well, so we can do something to these kind of people, and they will join together. So this can be done. We need not wait for the order from the main government or other authorities. Government employees are always hesitating to provide sometimes support, because they are asking now, they are replying, no, we don't have much enough information regarding that. Just I told you, the college professors are still not aware about this disability resource, discrimination or disability or attitude. Even in universities and colleges are not being constituted equal opportunity cell in Kerala itself. Kerala is the pioneer state in advanced education, higher education, etc. In our universities also, recently when I joined the Vice Chancellor as a member of his committee, and I raised the issues, please conduct immediately equal opportunity cell in the university itself. So many people are still unaware about the rights, the constitutions in 1995 Act, PwD Act. Now it has been closed, and the recent 2016 Act, and so Supreme Court opined, even after 18 years, 17 years, our PwD Act is not being implemented properly. Supreme Court said. And again, this 2016 Act is also the same condition. So it is better to interact people. So this was an opportunity to me to interact with people. Finally, organizing and conducting a state-level training program on capacity building in emergency response. Capabilities of children with disabilities in Kerala is an experimental one for the survey, first time in Kerala, to make this effort a sustainable one. The training module should be developed on the basis of the experiences gathered and learned from this training course, so that it could be replicated and reached to more people with disabilities. People are asking, yesterday, one call from Kerala, when I just arrived at Delhi, sir, any other program as you conducted earlier? We are waiting for such program. We wanted to get this training again. So among, we can cover nearly 3,000 people in Kerala. But right now the number is more than 12 lakh people. And recently, last month, and in my department, we started a course in MA Social Work in Disability and Action, purely for this course. And I myself prepared one paper, core paper, as a inclusive disaster risk reduction, and approved by RCA, approved by our academic council, university, and myself is responsible to take that course. So whatever the thing is in the act or in the government scenario, if it is not being put into application or bring in the concerned people who are suffering this kind of disabilities, otherwise this is a non-implementing situation, as like said the Supreme Court, though this is not being implementing. So now, right now, 25 intakes in this course start just 1 month back, and these people are very second semester. This course will start. My topic will start in second semester. So my request is that all over Kerala, and so all over India, all states should be undertaking certain special privileges and implementing this program through academic areas, research areas, and also should be a compulsory paper in inclusive disaster or disaster management in school, including school level, like in Japan, or in higher education level, university level, research level. So this is my request to you. Thank you for giving me an opportunity.
Thank you. Thank you very much. And now we request Dr. Anila to come and make the presentation. You have highlighted many important points for the process of empowerment. And I would take the first one is very important in terms of representation of in the committees. That is helping you in making the change. So, and many other points that will be deliberated at the conclusion. So thank you very much. Now, Dr. Anila would focus on some of the issues of empowerment. Please. Very good.
Namaskaram. In the previous paper, present by Dr. P.T. Baburaj, we were just go through the actions conducted by the Mahatma Gandhi University, Kottayam, Kerala. We conducted a training program on management of disasters among persons with disabilities in all the 14 districts of Kerala. At first, we completed the 4 districts programs, but unfortunately, we go through the disaster. During that time, I came to know that all the training programs are only training. We have to hear from the peoples who go through these flood problems. During that time, as a volunteer, when I visited each flood-affected homes, just to say to members of the home, dear mother or father or sister, just take your emergency kit and come with me to relief camp. What will be the feeling of that home members? When they reach that relief camp, what they can told to me. Many of the persons were experienced by lying in my lap. At that time, what I have to told to their relatives and what they told to me. This experience is I would like to share with you. Before and after the disaster, all the members of the family, community, and all the organizations had some sort of mental status. In this context, after the disaster, we continued the training program in remaining districts of Kerala. We took the feedback of the participants. Before starting the training, they had very anxiety about the nature of training. But after training, they had still anxiety, not regarding the training, but on how they face in coming days. That's some sort of phobia. So the IUCDS Department of Mahatma Gandhi University collected the feedback using some scientific tools and converted into a generalized conclusion. That is, I am presenting here as management of post-flood phobia among persons with disabilities of Kerala. For this, we set some objectives. First of all, we identified the persons with disabilities with post-flood phobia and explored their level of flood phobia before and after the training program. For measuring the level of their flood phobia, we prepared a flood phobia inventory. Inventory means the self-reporting items collections. Then, this inventory is administered among the persons with disabilities with the post-flood phobia based on gender, that is among male and females, and in different areas of phobia. Then the nature of this study was at first the survey technique. Then coming to the later sessions, it's maybe experimental. For this, we considered all the PwDs of Kerala, but we administered this inventory among hundreds of PwDs, especially in Alappuzha district of Kerala, because Alappuzha district is very crucial at that time. That's the 99% of these Alappuzha districts were coming under these flood problems. Then we prepared a package how we can manage this phobia among these people. So this package included videos, audios, counseling sessions, and personal interventions based on some selected sessions, that is, the well-being, permissive fear, and expressive fear. Because most of the peoples were expressed their fears mostly in these areas. We converted their or they decoded their responses and scientifically calculated whether the phobia is a real one. Second one, whether this phobia is higher in females or male, or it is higher in rural or urban area. But the findings showed that the level of post-flood phobia among PwDs at flood-affected area, whether it is rural or urban, in the dimension of expressive fear, there is great difference in before and after implementing the intervention package. That means they had a high level of phobia level before the intervention, and through the intervention we can minimize the level of phobia. That is, after the implementation of this intervention, the flood phobia, post-flood phobia, minimized among these PwDs. It is same as in permissive directions and in well-being directions. It means what we are doing for the PwDs for managing the disasters before, during, and after the time. We have to hear what they have to told, what they felt. The feeling of each person is very much important while we conducting or implementing the interventions. While we are conducting the training programs, we confronted many factors. That is, first one is when we considering the persons with hearing difficulties, we had one person for translating the content, that is sign language interpreter. But in local area peoples were not understood that sign language. Another thing, for the visually handicapped or the persons with a visual challenge, we implemented braille materials, but the local peoples doesn't know or not familiar with these braille materials. Another thing, persons with a locomotor difficulty, we had no appropriate seating arrangements. When the group come with a intellectually challenged, we first trained the caregivers, then with the help of caregivers, we trained the peoples. That's also our difficulty. But these are not a difficulty. We can overcome this by hearing and what they need. We have to teach them or train them to manage themselves, to manage their needs, manage their feelings, to empower them to exist in the field. Because this much I can done in the field. Being I belongs to low vision category, I am an associate professor in a college. I am teaching more than 200 professional students. It is not a task, but the task is to manage the persons with some difficulties. But it is very easy by knowing them who they are. And they will told me, teacher, could you teach me the way I can? At that time, I must have confidence to say yes. This is the concerning word to empower the persons with the disabilities to exist and nurture in the field. So, each and everyone born to lead and born to win. So we must keep our hands together to empower them. Thanks.
Thank you. Thank you very much for bringing this thought of empowerment and with the very pragmatic case study which you have done, and your university has done in terms of not develop yourself, but create yourself. And that is knowing who they are and what they can. Thank you very much for bringing this point. The panelists have mentioned about what to be done for the empowerment. Now we have a 10 minutes question answer so that you can react on that, what they have said, and anything you wish to add, that is also possible. And then we will have our chair comment, and then we will conclude this session. So we will have 10 minutes we have, so please raise your hand. Kindly address yourself and also address the person.
I am Mrs. Bratati Harichandan. I am presently working as Director SSCPD in the Government of Odisha. For the first time I am having such type of meeting. What came to my mind is that when Mr. Baburaj was talking about training the personnel, and Anila was telling about to make them as they are and not to develop them. I have a point, rather I have a suggestion that the best practices and the best measures taken by different agencies, be it government or be it anybody, NGO or any private sector, all those are to be documented, and those can be shown to others so that it can be replicated at other places. So that will be a positive story for all the participants, and that will be sharing of the experiences. That will be a learning for everybody.
Thank you.
We learn from our experience.
Thank you. Anybody else? Any more question? Just one sec, I'll come to you. I would also suggest this group just near the camera, they have not spoken since morning. So I would request them that who all are sitting here and wish to share some of the views, please do come forward. In the meanwhile, we will have this question. You frame your question and suggestion, whatever you have. And in the meanwhile, we can just, yes, please.
Should I? Okay, this is Dipendra Manocha. My question to the panelists are there any experiences of any individualized plans of mitigation being done anywhere? Because ultimately it's the individualized plan that really works. When the disaster comes, does that person with disability and people around know what to do when the disaster comes? That level of preparedness, has it been in practice, and whether persons with disabilities have been involved in preparation of any such individualized plans?
Thank you. Thank you. Very good question. Yes, please.
So this is my question to Dr. Jayakumar. So you gave a very good explanation about the information and education and the material. But the material should be accessible to all the disabilities, especially to the deaf people actually. The illiteracy rate is very low in deaf people. So we need to have, like with the videos, visuals, more visuals, and sign language interpretation, and subtitling in videos also. Because in schools, the teachers use oralism and don't use sign language. So it's my suggestion that you have it in sign language. It's a simple thing, so I hope the awareness and the impact will be more if we have that. But like now for coronavirus actually, that's a like natural disaster type of condition, like medical thing. So like these kind of things, I hope all these information is also disseminated in sign language.
Thank you very much. We will now request our panelists to reflect upon quickly on the questions which have been raised, and also Chair to...
Yeah, I'll answer this question about mitigation. There has been materials, capacities built on on certain disasters in certain states on how to, what about the do's and don'ts. I was talking about the latest initiative on preparedness and disaster risk reduction on psychosocial care front. That is first of its kind. There actually we, including, I'm sitting with the co-chair, they are actively taking it up in Cuttack city. I mentioned 6 cities of India, we are piloting it. And one such city is Cuttack city, where actually we are also actually training the Department of Disability Welfare and Social Justice actually on this aspect. So there has been initiatives, but I think actually this needs to be actually spread to the other places. NIDM is there, other partners are there, and I'm sure actually that in the coming days, this will be actually rooted actually into every level. I mean, there has been actually development on this aspect. I'm sure actually that in the coming days, it will be done in the coming years.
Would you like to say something, or you would like to react to this? No. Okay. You want to say something?
Thanks.
Sir, what is happening that in last 4 to 5 years, we are getting prolonged period of lightning strike because of scientists explain the global warming, atmospheric moisture, all these factors. 1 hour, 2 hour, it will continue, massive lightning. So we have got data around 400 people, 500, sometimes 600, 450, 350. Last 7-8 years, more than 350 to 400 people are dying. Most of them are farmers. Sir. But disabled data, I have not disaggregated. I'm sure some persons will there, those are exposed, especially open field. Our advertisement and capacity building is very simple, never go out. Even if you go out, you just sit down, lie down on the field, but not under the tree, not even in your car, simply lie down on the field, sit down on the field, not lie down, will again strike, sir. Never go into the water. So simple strategy, but we have not pinpointed how many disabled persons, sir. That is very interesting suggestion, sir. We will look into, because that my commissioner has come, I think we will address that issue, sir.
Just a question actually, I had a doubt, like, we have people from Odisha, Kerala, but nobody from Kashmir for the floods, or Latur, or Gujarat. Like, their experience should also matter. Like, if we have more inclusive people from those places also that had recent disasters like that, the flood, the earthquakes in Latur and Gujarat, then Maharashtra. So we can have like more diverse group.
Thank you very much. We are equally concerned because we had sent invitation to everyone. So the representation which have come, time is short, so we are just winding up. In that connection, we would just suggest that the invitation was sent to everyone, and large number of states have come, and few states have still left out, but next time we will try to have all the states together so that we can have the experiences of other states as well. Just to conclude this particular session, before I formally thank all the panelists, 5 or 8 points which have come up from this, to summarize quickly, that psychosocial care is the one way of process of empowerment of the people with disabilities affected by disasters. Database management is important, that how data is collected after the disasters, so the segregation of data, and that data pertaining to the disabled person, or how they are affected, which kind of disabilities, that is another. Third, it should not be a kind of adult-driven, but it's a holistic approach to be taken up when dealing with this. We need to have a policy and a strategy for taking this agenda forward for inclusive DRR. And then training and capacity building is very, very important for all kinds of disabilities and all kinds of different hazards. It's not that earthquake training will help in all the kinds of capacity building. Then we have another 2 points, that representatives of the PwD in any committees are important for empowerment. And enforcement, when it comes to the enforcements, whether the DDMA at the local level, Panchayat at the local level or the state level, that in the enforcement agencies also advices from the community must be taken. and the research orientation which has come up from the university. One, this integration of universities, and also that university has said that the venting out should be as a planned kind of an event, and that venting out has helped that phobia, in reducing the phobia due to disaster amongst the people who are affected. So these were the final take points, and there could be many which we would record and come with that, but I would request all of you to give a big applause to all the panelists, and so that we... Thank you very much, and thank you all the panelists and the delegates. Thank you very much.
Thank you, sir. We would request our Joint Director, sir, to please honor the panelists with mementos. To Madam Anila. To Dr. Jayakumar, Dr. Baburaj, sorry. Dr. Jayakumar. And the final one to Professor Santosh, the chair of the session. Now the final group photo for the panel, please. Thank you very much. We come to an end of the technical sessions, and okay.